Dr. Asch, welcome.
Chairman Alexander, Ranking Member Murray, and distinguished members of the committee, thank you for the opportunity to speak with you today. My name is David Asch, and I'm a practicing physician and a professor at the University of Pennsylvania. I'm here to talk about workplace health programs and their role in the nation's health. My summary message is this: I believe that employer-sponsored wellness programs have value to contribute. I believe that even though the health and financial benefits of these programs are often overstated, I believe that even though some of these programs, in the ways they are currently designed, risk treating some employees unfairly, but I'm optimistic about these programs going forward because we are learning how to design them to be much more effective and much more fair. Americans spend most of their time outside of the healthcare system. Even those with a chronic illness spend only a few hours a year in front of a doctor. But we spend about 5,000 waking hours a year doing everything else in our lives. And it's during those 5,000 hours when so many of the determinants of our health unfold. How we eat, whether we exercise, smoke, or take our prescribed medications. We can put more and more money into healthcare, but much of our health is determined in the 5,000 waking hours outside the reach of doctors and hospitals. Americans spend many of those waking hours at work, and employers have a large financial incentive to advance health, not just because of our system of employment-based health insurance, but also because healthier workers are more productive. And so more than 3/4 of large employers now have some sort of workplace wellness program targeting risk factors that you've heard about already that account for much of chronic illness, risk factors like tobacco use, high blood pressure, obesity, and the like. Unfortunately, it's a lot easier to know what conditions to target than it is to know how to do so. Managing these conditions requires substantial behavior change. Our nation has invested considerably in the science of medical treatment, as it should, but less in the science of behavior change. Our knowledge of how to break old habits and develop healthier ones is rudimentary, but it's getting better. Behavioral economics is one example of how we are learning more about changing behavior. Just last week, Richard Thaler of the University of Chicago won the Nobel Prize in economics for recognizing that we all succumb to irrational tendencies that compete with our long-term goals. Increasingly, behavioral economics has been used to help doctors and patients make better decisions, and I'm proud to say that the University of Pennsylvania is a world leader in this field. One such irrationality is called loss aversion. We are much more motivated to avoid a $100 loss than we are to achieve a $100 gain. It doesn't make economic sense, but it's how humans tend to think. We found this recently when encouraging overweight employees at a large firm to increase their fitness. In one group, employees were given $1.40 for each day that they walked at least 7,000 steps. That's a standard economic financial incentive. For another group, we structured it as a loss. $1.40 a day is $42 a month. So in that group, we gave each employee $42 at the beginning of the month, and we took away $1.40 for every day they didn't walk 7,000 steps. An economist would see those two designs as the same. For every day you walk 7,000 steps, you are $1.40 richer. But it turned out that those who received $1.40 were no more likely to walk 7,000 steps than those who received no incentive at all. But those who had $1.40 taken away if they didn't walk 7,000 steps were 50% more likely to succeed. Mathematically and financially, these two approaches are the same, but one worked and the other didn't. Most large companies are using financial incentives to encourage healthy behaviors. The vast majority of them do so by adjusting the premiums their employees pay for their health insurance. Although it may seem obvious that charging higher premiums for being a smoker or being overweight would encourage people to modify their habits, there is little evidence that programs designed that way often work. At best, they provide modest financial benefits to employers and unclear health benefits to employees. These programs offer promise, but they also draw criticism. I remain, nevertheless, excited about well-designed programs that help Americans change the behaviors they want to change, help them quit tobacco, help them lose weight, help them better manage their high blood pressure. Those changes are much less likely to come from typical premium-based financial incentives and much more likely to come from approaches that reflect the underlying psychology of how people make decisions, encouraged by frequent rewards, emotional engagement, contests, and social acceptance. Those are the ingredients of successful programs, and they are missing from most of what employers currently do. We know so much more about how to design financial and other incentives to motivate human behavior, far more now than even 10 years ago. I haven't seen much of this new knowledge applied effectively by employers, but there is no reason why it can't be. Thank you for inviting me to testify. I look forward to your questions.
Thank you, Chairman. I'm very excited about this hearing because I know a number of our witnesses have discussed in their testimonies behavioral economics. Mr. Asch, I'll start with you, with your expertise in this area. And then you said in your verbal testimony you haven't seen much of this new knowledge applied effectively by employers, but there's no reason why it cannot be. And so my questions for you, sir, are what might they learn from behavioral economists, just in summary fashion?
Sure. Well, thank you, Senator. I think I'll start by saying that there's a misunderstanding often about behavioral economics and health. Many people believe that if you use financial incentives to change behavior, you're engaged in behavioral economics, and I would say no, that's just economics. It becomes behavioral economics when you use an understanding of our little psychological foibles and pitfalls to sort of supercharge the incentives and make them more potent so that you don't have to use incentives that are so large. So I think that there are a variety of approaches that come from behavioral economics that can be applied in the employment setting and elsewhere. I mentioned one, which is capitalizing on the notion that losses loom larger than gains might be a new way to structure financial incentives in the employment setting in ways that might make it more potent and more palatable and easier for all employees to participate in programs to advance their health. The delivery of incentives more frequently, for example, or using contests, or certain kinds of social norming where it's acceptable to show people on leaderboards and contests and get people engaged in fun towards their health. All of these are possibilities.
So thank you very much, and you really need to study these different phenomena individually, I think, to have a sense of the growing body of work that is behavioral economics. Some of the ideas that I think we might incorporate into the government context, and tell me if any of these sort of pop for you, if you think they make sense. We need to continue to have unit or units embedded within government that do a lot of these experiments. We need to have a clearinghouse of best practices that others, employers included, might draw on. This doesn't have to be governmental, but it could certainly be. We on Capitol Hill might actually consider, aside from having a congressional budget office, we might have an entity or at least some presence within the CBO of individuals who understand how people would actually respond to given proposals. Do any or all of those make sense to you?
Well, thank you for your remarks. I think they all make sense to me, and one of the lessons that I guess I have repeatedly learned is that seemingly subtle differences in design can make a huge difference in how effective a program can be and how it's perceived. And we ultimately care about the impact of these programs. So I'm very much in favor of a greater use of these programs, but in addition, greater study of these programs, because I think we need an investment in the science that will help all of us get better at delivering these activities, not just in healthcare, but in other parts of society.
Makes a lot of sense. I'm out of time. Thank you.
Thanks, Mr. Chairman. I want to thank the panel for being here and for your testimony. Senator Murray indicated that some wellness plans use both penalties and rewards that can be as high as thousands of dollars a year. We've heard that Dr. Roizen's program uses a 30% penalty, the limit that the EEOC has set when it issued the rule last year. So my question is basically this: based upon your research and other behavioral economic research, is it necessary to use such large penalties or rewards? And if not, what would you recommend such rewards or penalties to be?
Well, thank you for your question, Senator Casey, and I think you've identified some critical issues at the interface of effectiveness and voluntariness right there. So I think a lot of employers are under what I would consider to be the mistaken impression that the way to make incentives effective is to make them larger and larger. And that naturally leads to very large incentives putting large amounts of money at risk, whether they're in the form of rewards or penalties. And we've heard, of course, that penalties are more off-putting than rewards and actually sort of jack up the concerns about the lack of voluntariness. But I think it's potentially a mistake to think that way. I actually think that that is old, outdated thinking, that the only way to increase the potency of an incentive is to increase the size of an incentive. I think instead, we know from years of research now in behavioral economics that the way we design incentives probably has much more of an impact than the amount of an incentive. You can imagine, for example, a $500 incentive that might be bundled into someone's paycheck. Well, if they're paid once a week, that's $10 a week. It looks much smaller then. It's put alongside all sorts of other elements in the paycheck. It may not even be seen. It's directly deposited. You can imagine handing someone 2 crisp $100 bills, a much smaller incentive, and have it be much more potent emotionally. I think another mistake that employers make often, but they don't need to make, is setting explicit targets for goals. If you believe that your employees should be at a BMI of 25, which is, let's say, the upper limit of normal, and you set that as the goal, that's a good way to make people whose BMI is 26 lose a few pounds. But if your BMI is 40, that's a demoralizing goal. What we care about is improvement. And pay for improvement programs are going to be far more effective for the people who we fundamentally need to help the most. So I think both design elements with the structure of incentives and design elements with the targets for incentives can be improved by most employers. And I'm really optimistic that they can do that.
Thank you, Senator Casey. Senator Cassidy.
Dr. Asch, I'm an internist, as you, and although this is a HELP committee, which is not Medicaid and Medicare, nonetheless, I feel as if that which we're doing in the employer-based setting has a fairly mature science. But as I think of my patients whom I used to care for in the Louisiana public hospital system, the Medicaid patient or the uninsured, it's a bigger problem, if you will, some of these wellness issues. And if you're in Philadelphia, you probably have a practice that's somewhat similar to mine. How can we translate some of this, which we have been discussing for the workplace, into the Medicaid population, which statistically has a higher incidence of chronic disease, morbidity, et cetera, than the workplace?
Well, thanks for the question, Senator Cassidy. I think in most cases these activities can translate. I do think that employers have a special role and a special trust connection with employees that may be not as high as the trust relationship people have with their doctor or with their hospital, but might be potentially higher than people have with their insurance carrier. And that trust is an important determinant of the success of these programs.
Let me stop you for a second, because as I think of my Medicaid patient, there's a structure associated with an employer relationship. And that structure allows them to give you 30 minutes off to go walk around the track if they have built one there. But Medicaid patients taking public transportation to their clinic appointment or cigarette smoking, and there's nothing you can do on their Medicaid to incentivize them to stop smoking, I guess I'm not seeing that it's as easily translated. And by the way, I'm willing to open this up to anybody, because to me it actually seems almost an apple and an orange.
Well, so we have run some programs that were employer-based that were designed to reduce the burden of tobacco on employees. We did 2 studies, one at General Electric and one at CVS. Both were highly successful interventions published in the New England Journal of Medicine and later adopted by those 2 companies. They reflected largely positive financial incentives delivered to workers to help them reduce the burden of tobacco. There's no reason why programs like that could not also be introduced into the Medicaid population. They're incentive-based. They were successful. We can think of translating some of the science and the learnings that we've developed from the employer setting.
Now, let me stop you, because again, you'd be familiar with the structure of Medicaid, which if it's managed care, they contract with a provider to provide a service at a certain rate. And if it is fee-for-service, you're just paying the bills as they come in. But typically, the patient is not directly impacted by this. The Indiana experiment may be a little bit different, in which they pre-funded health savings accounts. You could build an reward for that. So are you thinking, when you say build an incentive, and again, I open this to anyone, how would you do that for the Medicaid as commonly structured under the ACA or any other program?
Well, I'm not sure I would know how to do it as it's commonly structured, but it doesn't mean that it couldn't be rethought and that state Medicaid agencies might think about waivers or the like that would enable them to engage in those kinds of activities in order to achieve their mission. I'm not sure that they can do exactly what I just described under the rules as they are now, but under changed rules, They might be able to.
So the state could apply for a waiver asking for the flexibility to incentivize this sort of behavior, trying to translate that which you've successfully shown works for an employer, but to do it for the Medicaid population.
Yes.
I totally agree with that.
And would you elaborate or just accept, just to agree?
Well, I don't want to take too much time, but basically it is, how do you get both programs that work, leadership and incentives into the Medicaid program, and obviously Indiana and even Ohio are doing major efforts to do that and seem to be succeeding.